Hi, I'm Michael Bruinix, and I'm a clinical social worker at Providence Care Hospital. I have a specialization in personality disorder. I worked with a lot of clients with personality disorder and mood disorder over the past 5 years, and I've created a presentation that I've been teaching in the community for the last few months, helping people with clients where they don't really know where to go, don't know how to, the things that they're doing aren't really working, and they're not sure why. So what I did was I created a clinical training series about working with people who might have underlying personality disorder issues, might be diagnosed, might not. Some things we're going to be covering today is what is a personality disorder, how do you recognize it, even if it's not diagnosed. And I think a lot of people have underlying personality disorder issues and then it's not necessarily diagnosed on the file or when you first receive a client. So really important to identify that. We're going to also look at some causes of personality disorder, different types of personality disorder, and we're definitely going to be diving into the research. So let's get started. A lot of personality disorder information comes from the dialectical behavioral therapy created by Marsha Linehan. She herself had borderline personality disorder, or what's called BPD. She went to school and she got her doctorate, and then she decided that she was going to create a therapy for people with personality disorder, and she really focused on borderline personality disorder. So we're going to be looking at what Marsha Linehan's take is on the causes of personality disorder, and we'll do a deeper dive here. So I've got a slide deck just here to the side, and I'm going to use that as a way to focus the talking points to make sure we're just touching on the main points as we go through. So the very first thing that Marsha Linehan states is that the core of all personality disorder is emotion dysregulation. What she's trying to get at there is that when someone has a personality disorder, they tend to have emotions that get very, very strong. So if we look at a scale of 1 to 10, people with personality disorder often they have, say, fear, anger, sadness, guilt, shame, or joy. 6 types of different emotions that people typically find they have. Of course, there's more, such as surprise and disgust. And we know with the research that babies can elicit the emotion of surprise and disgust. But today we're going to just focus on the 6 emotions just as a starter to get you oriented to how to work with people who are having trouble with their emotions. So the way I like to explain it to people is think of someone with personality disorder. What happens is imagine they're walking into a building and there are 6 elevators. There's a bank of elevators, and each elevator would be a different emotion. So on a given morning, on a scale of 1 to 10, they might wake up in a state of fear. They might wake up where they're feeling really angry, they don't know why, or they might feel particularly sad. It's chronic, it's lingering, it's around, and they don't know what's going on. So why I talk about it being elevators is when someone has personality disorder, often they feel like someone else is pushing their buttons, meaning they get a text from somebody, or they get a notice from the landlord, or maybe you as a worker say something and it suddenly sets them off. And now they were like a 4 angry, but now suddenly they're an 8 or a 9, and then they don't know how to bring it down. It feels like someone else is pushing their buttons all the time. What Linehan was talking about in her research is that people with a personality disorder, the core pathology, instead of breaking out into the DSM-5 and thinking about all the different dimensions of it, is that just emotion regulation is a core issue for people with personality disorder. And we're going to get into why that is. And we're looking at 6 different emotions, and we're thinking about it being on a scale of 1 to 10. So let's just look at that for a second. If someone has those 6 emotions, going to repeat it, fear, anger, sadness, guilt, shame, or joy, right? These are emotions that they find very troubling. And you might think to yourself, well, is joy a difficult emotion for people? You bet. I was working with a client once who, when she was seeing her daughter was under the care of Family and Children's Services. And what happened was when the session ended, she felt like she wanted to self-harm. I've also had many clients who around Christmas time or the holidays, they're feeling really intense emotion. And part of it is they have unmet wants and needs where they were really hoping Christmas would go a certain way. And then year after year, really disappointing how it goes with their family. So it should be a state of joy. You would think the holidays would make someone feel joyous, but they have all kinds of feelings underneath, all kinds of thoughts underneath that make it so what we consider positive experiences actually can be very dysregulating. And by dysregulating, what I mean is that those elevators are moving around all the time and they don't feel like they have any control. In fact, one of the things they often say is that they externalize their issues by saying, you know, if you were a better worker, if you were a nicer doctor, if you were a kinder receptionist, I wouldn't be feeling this way. When they come to access services, often there's a sense of blaming the other person trying to help them. So that's another sign that you know, someone has a personality disorder. Not everyone does that who has been diagnosed with a personality disorder, but certainly a trait with borderline personality disorder where people feel like they're just in a victim state, something's happening to them, they're not sure why, and it can feel very chaotic inside as these elevators move around. So some people wake up and they're just at a certain level, say on a scale of 1 to 10, their sadness is a 7 out of 10, not sure why. The research from Bowlby in Maine and Ainsworth indicates that a lot of that has to do with a personality disorder actually being an attachment disorder, where we have a lot of unprocessed grief underneath that's keeping those intense emotions firing and keeping the client really agitated. Another thing that you'll find is that the elevators are moving around really quickly, and by that I mean their emotions are just very fluid. Even within a conversation, even within a session, you'll find that clients are moving in different states where they're suddenly really feeling guilty, or they have a thought they shouldn't. They feel like, oh, that was a bad thought. And then that can plunge them into feeling really, really deep sense of shame or low self-esteem. So when you think about it, being in their skin for a minute, you know, if you're feeling like your emotions are constantly out of your control, as though somebody else is in charge, it's a really helpless situation to be in. I mean, it can be really, really frustrating, and it can feel like if things around them were just better, then their life would be better. And you know, a lot of us do that too, right? If we feel like we have more money, or we have a healthy relationship, or our job is going well, then we feel better. So one of the things we're going to notice here is that when someone has a personality disorder, they're doing exactly what we do, they're just doing it more. So it's not that they have problems that are distinct and unique from us, it's more like they have the same problems, just they're more intense. They have the same emotions as us, but they tend to be more intense. About 20% of people who have personality disorder have another feature, which is that they shut all those emotions down. It's as if their emotions are down at a 0 and they try to lock them out. That often happens because cognitively they're trying to filter their reality, they're trying to think their way through things, they're thinking more than they are feeling, and that has real advantages in that your mental filter stops emotions from coming up. So as you may know from different defenses, if we talk about intellectualization and rationalization, moralization, compartmentalization, what are we doing there? We're using our mind to kind of close down emotions, and some people get very good at that. Problem is, if you have those emotions closed for too long, you'll start to feel like you're not feeling anything. It's like a chronic emptiness. You can feel like a numbness or a hopelessness that fills that void instead. There's only so long people can have that, which is what leads to other types of dysregulation. So what Marshall Linehan's emphasizing here is that when someone has behaviors where they're acting out, what they're trying to do is they're trying to cope with their emotions inside. So Marshall Linehan calls those maladaptive behaviors. Those are the things that our clients are often really distressed about. They can't stop self-harming, they can't stop their eating disorder, they can't stop using substances. What they're doing is they're trying to use different behaviors to put out those emotional fires, or they feel so empty inside that they're trying to feel something, some kind of aliveness inside. So that's the reason the person's acting in that particular way. Now, I myself don't think that's just for people with personality disorder. I think people with mood disorder do that, certainly substance use disorder. I think there's actually a core pathology there in terms of how people cope and function with emotions is they use something external to help them feel better. So we'll get into the 5 areas of dysregulation now. What Marshall Linehan's saying here is that principally, okay, let's say they've got these different feelings that are stirring up inside and they're at different levels at different times during the day. Okay, they're emotionally dysregulated. They don't feel like they're in control. So what does that lead to? Obviously, when your emotions get really high like that, you're going to start having different cognitive distortions. It's not just and be feeling cognitively dysregulated. As you know, when your emotions get really hot or really intense, it makes it so your thinking isn't right either. So it leads from emotion dysregulation to cognitive dysregulation. And then that in turn leads to behavioral dysregulation, meaning now that your thoughts and feelings are kind of out of whack, you can't figure out what to do, and you don't feel like you're in control of them, then you start acting out in certain ways in order to try to calm them down. And then, of course, if you have enough behavior dysregulation, then that's going to lead to interpersonal dysregulation, where now it affects your relationships with other people. And this is a core feature with personality disorder, is that there's some kind of impairment. Either it's your social functioning, either you're out in society and you aren't functioning well, say at a Starbucks or at a store. Small things can set you off or upset you. And that doesn't necessarily mean you're getting angry. It could also mean you feel sad or helpless, or maybe you're suddenly afraid by something small that somebody does. So there's definitely a social impairment element to this. Additionally, you're going to have a work impairment. Often people with personality disorder, they feel like their emotions are so intense that they're unable to work. It's very, very important that people get back to either volunteering or working. The research shows that when they do that, it creates a stronger self-esteem, and then they have a better recovery. So that's you have a social element, and then you have a work element, and then often there's dynamics within their own family where they grew up in. You know, if we were exposed to the childhood or adolescent or adulthood that they were exposed to, you can quickly see the factors that are stirring them up and making them feel in this particular way. So family dynamics are really important, not only in the family that they came from, but the family that they have now, and the circle of friends that they have now. So where you're noticing the difference between someone who's having different challenges, you're really crossing that threshold with personality disorder when you have an impairment in one of those areas, one or more of those areas. When you have the emotional dysregulation, and then you have the cognitive, and then the behavioral, interpersonal, what you really want to focus on here is that deep down, it's their sense of self. Their sense of self is often very, very low. They see themselves as hateful or defective, or they're broken in some way. And that, people aren't born that way. They're taught to think about themselves like that. So we need a lot of compassion when working with someone like that. But what I'm saying is that those different elements of personality disorder stem from their sense of self, their sense of identity. So a lot of the work that we're doing here is very important because their identity is at stake when we're working with them. Now, there are 10 different types of personality disorders, and the way clinicians talk to each other about that is they talk about clusters. So there's cluster A, which includes schizoid, schizotypal, and paranoid personality disorder. Those are 3 different types. And we don't see a lot of cluster A in outpatient clinics. Like, I've been working in outpatient clinics for over 5 years, and sometimes people have features of cluster A. And with paranoia, you're often not going to come because you don't trust other people. With schizoid personality disorder, you're not going to come because human contact and connection is not a high priority. And then with schizotypal, often there's a disordered type of thinking. They have strange associations, and so they're not likely to access help. It's very important, if you can, to try to create a differential diagnosis between that and schizophrenia or psychosis. But if it's persistent and they're lucid, I think that would lean towards more of a schizotypal presentation. But of course, I'm a social worker, I can't diagnose. What I'm saying is you can try and pick up on different traits that people are presenting with, and then see if these clusters kind of help you. Because if you look at the way personality disorders are laid out in the DSM-5, it can get really complicated really quickly. For example, with borderline personality disorder, there are 9 criteria someone can have in order to say that they have personality disorder, and you only need 5 of them in order to be diagnosed with personality disorder, in order to have traits of borderline personality disorder. So if we think about 5 traits over 9 different types of symptoms, that can lead to 256 different clinical presentations just of borderline personality disorder. And we know in the research that often when someone's been diagnosed with a personality disorder, there's a high level of comorbidity or a high chance of concurrent having another personality disorder as well. It also combines in with Axis 1 presentations such as generalized anxiety disorder or major depressive disorder. And sometimes that's why with personality disorder, it doesn't really respond well to psychopharmacology because it's something deeper inside them. So it's not simply like depressive symptoms. Strongly recommend you consult a psychologist or a psychiatrist to get more detail on that, but I'm just trying to provide an overview today to give you a sense of what is a personality disorder and what isn't, and some things to consider when you're looking at that. So with cluster A, you're looking for odd or eccentric behavior. Sometimes you might see features of that as you're talking to them. Cluster B has histrionic personality disorder, narcissistic personality disorder, antisocial personality disorder, and borderline personality disorder. And those four personality disorder types, basically, it has to do with feeling dramatic. There's a dramatic presentation. They're very, very emotional, and often it seems like their behavior or their thoughts are kind of erratic. There's a high level of impulsivity, and sometimes you're talking to someone and you just don't know why you can talk and talk and talk, and it's not really getting anywhere. For myself, I've had different interactions with people with histrionic personality disorder, and the way I describe that is that it's like it's an inch deep but a mile wide. You can talk about all sorts of different topics, but no matter what they're talking about, it never feels like they're talking about what they're feeling. They can describe things and they use lots of words, and you're kind of thinking to yourself, like, what is going on here? Like, you're trying to connect with them, you want to have empathy with them, a connection with them, and it's not happening. And there's different reasons for that, and there's different types of presentations for that. But of course, I'm just giving you some things to just think about in general, so that when you're sitting in front of someone, you might be thinking, I wonder if that is histrionic presentation. Like, I wonder that drama that they keep talking about, maybe there is an underlying element of a personality disorder there. An important thing to note is that often psychiatrists are reluctant to diagnose someone with a personality disorder until they're over the age of 18, because when people are younger, they can feel very, very intense emotions. And that's just part of adolescence. That's just part of our development. As we get older, we start to learn how to regulate those emotions. So what Linehan was talking about with the dysregulation, that can very often occur with people who are, they're growing up, they're teenagers, they're adolescents, and they're trying to figure out sort of who they are and where they're going. And so we don't tend to diagnose until people are in their early 20s, because we want to see if that just kind of goes away or it's just part of their development and the milestones that they have to reach. Cluster C, you see a lot of this. I certainly do in outpatient clinics. It's around being a dependent personality disorder, avoidant personality disorder, or obsessive compulsive personality disorder. With the dependent personality disorder, you're going to notice they can't make decisions on their own very well. They're going to have people in their lives that often tell them what to do and how to do it, and they kind of follow along. Obedience and compliance is a really important part of that. And this can combine. You can see people on the one hand, they're feeling like or they may present like they're a borderline personality disorder, and then suddenly they can switch gears and suddenly feel dependent or regressed or feeling small or young. And so personality disorder is often a very fluid state. People can have these chronic states that they're kind of in, but they can also have some lability where they're moving across in terms of state. I'm going to get into that in a minute with an idea from Nancy McWilliams. But just to finish up on cluster C, what you're seeing here is that principally anxiety or having a fearful response to reality is guiding a lot of what they're doing, and that's why avoidant, dependent, and obsessive compulsive personality disorder are kind of clustered together as cluster C. So with dependent, it's kind of a fear of making decisions, and they're kind of afraid of making a mistake. A lot of that, you'll hear that as an undertone when they're talking to you, that they're concerned about what is right or what other people think. They're other directed a lot. Avoidant, there can be social anxiety, social isolation, those type of features. And with obsessive compulsive personality disorder, I should say, the idea here is that they have a real strong cognitive rigidity. Just to explain the difference between OCD and OCPD, I was working with a client once who had OCD, and he was just tormented by these rituals that he had. He had to shave on the left side of his face like 35 times, and on the right side of his face it was like 30 times, and he had to put his pant leg on with his left leg up and down, 10, 20 times. There was a specific number, and then his right leg, and then finally could put those on, and then his belt was a certain way, and before he left his house he had to check locks. Those are rituals. That's very different from obsessive compulsive personality disorder. To do a deeper dive on that, you can look at the personality disorder criteria in the DSM-5, the Diagnostic Statistical Manual. The latest one came out in 2015, and it'll break it down for you there. But what I'm trying to do on this video is save you time, compress some ideas, and just get you oriented to what you might be seeing. If you're a police officer and you're working with someone in the public, if you're a caseworker and you're trying to figure out what kind of services that your client's going to access. They've been working with other workers, and it just seems like nothing's going anywhere. You might be, what I'm asking you to do, inviting you to do, is think, oh, maybe there's a personality disorder, or there's some underlying personality features that's preventing them from moving forward. So with obsessive compulsive personality disorder, what you'll notice is there's a certain type of rigidity. There's a need for control, and that's in order to stop feeling afraid of various things. So with feeding into Nancy McWilliams now, what I saw was an amazing YouTube video where she was talking about how personality disorders have different themes. So with narcissistic personality disorder, the theme there is sometimes they're feeling shame and sometimes they're feeling a grandiosity. So what's happening is they're in kind of a fluid state where at times they're feeling very shame-based, and they might even, self-harm. They might isolate. They're feeling very disappointed. They're feeling like a failure. And then other times they're having grandiosity. So self-esteem regulation is a core theme for them. If you remember back from days being in high school, you'll remember that in English there were different themes, say in Shakespeare. And that's what Nancy McWilliams explains in her video. I cite that video in my ebook at the very end, where she talks about the different themes that that clients can present with. Another theme that you might see, say, with dependent personality disorder, is that there's a state of being very dependent on you or people around them, and then their challenge is to feel independent. So that's the theme in their life. If you look at all the decisions, all the things they're thinking, all the things they're focused on, there's a core theme there that's an issue for them. I would say with someone with borderline personality disorder, core theme there is trust. When you're working with someone with BPD, what you'll notice is that there's times where they want you close. They want to be connected to you. They have an urgent voicemail, or they're coming down to make an appointment with you. There's a sense of urgency, like I need you now, and I need you close, and I need your help. And then there's other times where they push away, they don't show up, they don't want to be near you, or they're in a state of distrust. So they're in that fluid state of between distrust and trust. And so what you'll notice is there's a lot of chaos in their life because they don't know who to trust, they don't know where to turn, and they don't know what's going on inside. They feel very confused by these intense thoughts and emotions that they're having. So when someone has personality disorder, I have a lot of compassion for them because they're not sure what to do and where to go. And I think the work by Linehan is very insightful and very helpful. So let's look at the clinical picture here of what it's like to be in their shoes, what it's like to be them. What we're going to notice is that they have an inability to self-soothe. No matter what they do, it doesn't feel like it's enough. Often clients with who've been diagnosed with BPD, they're trying to pull in their doctor. They want their caseworker. They want people on the crisis line to respond. They want their family to respond. They want their partner to respond. They want to go down to the emergency room at the emergency department, and they want someone there to respond to their emotional pain. They don't feel like they can soothe it. They need someone to take it away. That's a very common feature when someone has borderline personality disorder. They see themselves as broken. They see themselves as no one can help them. They've tried different things. They've fired different workers. They've tried different doctors, they've maybe even tried different medication, and nothing's working, and they feel like something's wrong with them, a deep sense of failure. It also ties into having feelings of helplessness and hopelessness. Imagine being on the inside like that, where these emotions are moving around and you're having different thoughts and you're in different states, different emotional states, where suddenly you can trust someone. Now your gut's telling you, no, I can't, or you remember in your mind times they betrayed you or let you down or disappointed you. That can be really, really internally chaotic. And we know from Freud's work that what he was saying is that intrapsychic problems become interpersonal problems. That's one of the things that we notice in therapy or working with people when we're trying to help them with recovery, that they have things going on the inside, and then they express that in terms of now it's your problem, you've got to fix it, you've got to help me, you're the worker, and you can get feeling kind of frustrated, or yourself feeling kind of hopeless, because this is just it's chronic and it's unending. The other thing here is that they often reenact childhood abusive relationships. You may not have an angry bone in your body, but when you're working with someone who has moderate to severe personality disorder, you may find that they're saying and doing things that are really frustrating you or annoying you or irritating you, and that your feelings can be a sign that you're working with someone with a personality disorder. Winnicott is a famous clinician from the 1940s, and he states that the feelings you're feeling inside, what clinicians call countertransference, can really serve as a guide to let you know where to be effective and what to say and how to say it. And I don't think a lot of people get training on that, particularly when someone has a personality disorder. So we're going to be touching on that in later modules and later sessions. But for today, I just want you to know that it's very common that when someone has a personality disorder, they're going to reenact relationships that they have from their childhood. I would argue actually that all clients do that, but people with personality disorder are more, you'll feel their feelings more intensely, and they will feel their feelings more intensely. So the challenges for our clients when we're working with them, should they have a diagnosis of personality disorder, and a lot of people, it's undiagnosed, might come across as bipolar type 2, also complex PTSD, or they may have different features saying that they're part cluster A, part cluster B, part cluster C. The diagnosis for that is personality disorder not otherwise specified, PDNOS. And whether they have some features, some traits, or they have a formal diagnosis, what you're going to notice in terms of being able to identify, hey, is the person I'm working with right now, is it possible that they have a personality disorder? Things you're going to want to key in on are they have difficulty respecting rules and authority. Okay, you might be making suggestions for homework. You might ask them to come to a group and they say no. You might ask them to come to individual sessions and they might no-show. Now, it's clear in the research that not everyone who no-shows has a personality disorder. What you want to look for are patterns. Are they having police involvement? Do they constantly have issues with landlords? Are they having trouble with rules, say, at school, or if they go back to school or in the workplace? Has authority figures and have rules been a real challenge for them thematically across their life? That's when it's more certain that you're looking at something inside their personality structure. Another thing the research indicates is that a lot of people with personality disorder have what we call alexithymia. And the easy way to explain that is to say they have difficulty with communication skills. You can ask someone how they're feeling, and you're going to get one of two responses. Either their responses are very simplistic. They'll say things like, I'm feeling mad, bad, glad, sad. It's like they have a very primitive level of understanding how to convey to you what's going on inside of them. Or they're having such a tumultuous, such a fluid inner state, they can't describe very well what's going on because it's changing so rapidly. It's not their fault. It's not. It's just a skill they have to acquire. We run groups where we teach people like a wider verbal vocabulary in order to explain that different emotions have different ranges. So again, like the elevators, we're trying to say emotions can appear low, moderate, or high. And a lot of times people who have a personality disorder just don't have the words or a way of expressing what's going on inside. So that's why Marsha Linehan focuses on a couple of things. She focuses on her module of emotion regulation, teaching people that emotional lexicon, giving them a range and showing them different words they can use in order to explain what's going on inside them. And she also has a module called interpersonal effectiveness, where she's talking about basically people skills in terms of communicating and improving your communication style. So what I really like about Marsha Linehan and dialectical behavioral therapy, which we're going to jump into in a later module, is that she has her approach to all of this isn't the client is the problem. It's that they don't have the skills to deal with what's going on inside. So when a client's coming to me and they're saying, look, I need help, and then, I've tried this, I've tried this, I've tried this, I was with this therapist or this worker or this agency, I'm like, okay, how's your skill level doing? How's your communication skills? Can you work inside groups and explain what's going on, or even in individual therapy? Do you feel safe enough? Do you feel like you can trust someone enough that you can say what's really happening inside you? These things all take time. And it's very important to be patient and kind and compassionate, but also learn how to set limits when someone is presenting with these types of challenges. And what makes that particularly difficult is the person with personality disorder often doesn't feel like it's their problem. So they have a really hard time with accountability, and they have a hard time with problem solving. They want you to solve the problem, they want you to fix it, and if it's not being fixed, it's your fault. So that externalization, research shows that the more a client externalizes and says it's other people's problem, that's why I'm unhappy, the harder it is for them to benefit from treatment or get accessing services that can help them move forward. So if we look at rules and authority, communication skills, and difficulties with accountability and problem solving, like that's a difficult clinical presentation to work with over weeks, months, or years, because the pressure is always on us. We're feeling really intense emotions while we're working with them, and we're going to get into that in later sessions. But for now, I just want you to see those are overarching patterns, and if you can see that your client has those type of difficulties, then likely you're dealing with someone who's having some trouble with the personality structure that they have. Of course, our challenges, we were looking at their picture of reality, but now as clinicians, as workers, as direct care service providers, what are our challenges working with clients like this? Well, they show that when they're working with us that they're highly distressed and dramatic. It can be hard to hear the same story over and over again. It can be hard to hear they've broken up with their partner again, that they've gotten in another fight with another family member, and that it's just a lot of drama, a lot of chaos. It can be hard because we're offering what we think are very effective ways of problem solving and working through it, but because their emotions are so challenging for them, they're so intense and they're so challenging and so fluid, it can be hard to keep working with them effectively because they don't respond to our suggestions very easily. So that can cause a form of burnout, or we start feeling apathetic, or we get disinterested, bored, really frustrated. These are things that we as clinicians and workers, leadership can feel when we're working with clients who are presenting like this. They have intense and rapidly changing emotions. They might even have verbal or physical aggression. That can ramp up our feelings. Suddenly they're talking to us and our fear goes from a 4 to like a 10. We're concerned for our own safety. That makes it extra challenging for us. They have chronic and acute self-injury. I've had clients that want to show me their wounds. They've been cared for at the emergency department and they want to show me. And I'm like, it's hard for me just to watch that they've hurt themselves like this, but I've got to go deeper and say, okay, where's this person coming from? Why are they feeling that way? What can I do that can help them in this moment here and now and moving forward? But when they present with either chronic thoughts or impulses to commit suicide or self-injury, that can put us in a lot of distress. Their substance abuse, their feelings of dissociation, they're not feeling like they're real in the room. They either feel like you and reality aren't real, or they are not real. That's called derealization or depersonalization. Can make it hard because we can talk about something, suddenly it triggers a traumatic event in their background. and then they don't feel like they're in the room, they don't feel connected, they don't know what's going on. So their dissociative presentation as well can be challenging for us. They're taking risk, they're engaging in risky behavior, and it can be hard to watch that, to bear witness to that, to try to support someone, to look after themselves. A lot of self-care skills come into play when you're working with someone with a personality disorder. And we talked about them either trusting us or not trusting us. One of the things that they often do is they limit test. It's they want to see, do we still care? Imagine if you're feeling afraid of someone and you're not sure to trust them, you're going to keep doing things to see, can I trust them? So I'm late for an appointment. Oh, do they get angry? Do they get upset? How do they respond to me? I'm late again. I'm late again. I'm late again. It's sort of a thing of do you love me now, or do you still care for me now? Do you want to work for me now? Work with me? They're testing and testing and testing because their sense of trust is completely eroded. They don't trust themselves. They don't trust you. They don't know what's going on. And so limit testing like that, where there's missed appointments, no shows, they're not doing homework, that can be very challenging for us. And when they do come for help, it's often very crisis driven, right? When they're coming, it is urgent. They've left things for too long and now it's building up, or they're just presenting every day with different crises, just bouncing from crisis to crisis. When I run groups like Managing Powerful Emotions, and I ask people, hey, do you find, it's just a show of hands, do you find that you're bouncing from crisis to crisis in your day or your week? There's just a forest of hands that go up. It's amazing how many people out there are just in emotional crisis and they don't know what to do and they don't know where to turn, and they're hoping someone somewhere can help them out. And after a while, that can be very distressing for us because they're presenting in such an elevated state. It's really difficult for them, and it's difficult for us to regulate our emotions, which is what we're asking them to do. We have to model the behavior we're asking them. It can be challenging for us, client after client or day after day, to keep regulating our emotions when their emotions are so intense. They can be demanding and blaming others for problems, as we talked about. And then the research shows that when someone is trying to even seek help, about 50% of people don't return. So the dropout rate in therapy is about 50% on average in the industry. So even if you put all that work in, even if you're well trained clinically, you're doing your best work, they're doing their best that they can do, it's still hard for them to stay in therapy, which can make it challenging to keep having hope, feeling resilient, and continue to work with your client. So now I'm going to get into common therapist reactions. So when you're exposed to that type of presentation, when you're exposed to those types of challenges and difficulties, there's a couple of urges that clinicians and therapists can have, workers can have, that aren't helpful for the client. Don't let the client move forward very well. First is an urge to rescue. We feel like we've got to fix it. We feel like the pressure's on us. We've got to do something. If you're working with a client and it feels like you are doing more work than they are, or it feels like you've got to pull out all the stops and make something happen, that's often a rescue fantasy. You want to be the person that can help them when in fact it's their skills, it's their stage of contemplation regarding change. If we look at motivational interviewing and the stages of change, it can also be life factors. What's going on in their life right now? If they're caring for family members or they've got children and there's a lot of crisis going on in their life with the people around them, it might be hard for them to change or to stick with something. So sometimes we feel like, wow, they're in such a bad position. I've got to do something. I've got to help in some way. And so this urge to fix it, where we feel like we're just doing more and more and more. And what you'll notice when someone has a personality disorder is it doesn't matter. You can give them an ocean of help. It's not going to make any difference. It's unending. It'll feel bottomless. That's why I'm using the word ocean. It'll just feel like their problems are bottomless, their feelings are bottomless. It'll feel like the crisis is unending, and so fixing it doesn't actually fix it. And you'll know this if you think back on clients where I've done this too, where you're trying, you feel like, okay, I'm going to go the extra mile for this person. When someone has a personality disorder, actually it's counterintuitive to think that's not going to work for them. I've got to do something different here. And if you look at your caseload, if you're working with people and you're like, wow, I'm really stalemated here, I'm stuck, I keep working really hard, and then they're backing in and out, or they've been passed from organization to organization, worker to worker, and you're thinking, what's going on here? Oftentimes, the underlying personality disorder structure is getting in the way, and then we have to reconsider how we're going to interact with them and what's going to be effective. And fixing it, rescuing, doesn't work. If you think back to clients you've worked with, how often does rescuing work? You'll see it's not very often, if at all. I've never had it work. But I can tell you why sometimes I get into feeling like I need to fix it for them. Sometimes I'm afraid of their self-harm. I'm afraid that if I'm talking to them right now and they go out and they say, okay, well, I'm going to do this. I'm going to hurt myself, or I'm going to kill myself. Wow. When I was earlier in my practice, I would get really afraid. I was feeling like I've got to do something because I don't want that to happen to them. I care about them, and I was feeling a pressure inside, which when someone has personality disorder, they use a defense called projective identification. I'm hoping to get into that in another video, but some amazing clinicians such as Gabbard and Greenson and Kernberg talk about that mechanism. It's very, very important to understand. If you're feeling like your emotions are very, very intense and you feel like you've got to fix it, sometimes it's because you're in a state of fear and they're making you feel the fear they have inside. They don't feel safe, and then suddenly you feel like you've got to do something about it. Another thing that can happen with someone with personality disorder is they can get really angry, and it might make you feel either afraid or angry. They might threaten to sue you. They might threaten to go to your boss, file a complaint with your college. And so we're thinking, oh, I've got to fix it. There's a pressure on me, like I've got to do something here, because people with personality disorder can make those kinds of threatening gestures or have those kinds of responses, and then it makes us feel like we've got to fix it. And the reality is, we can't. And if you're thinking also about clients in the past, like I do, there's been times where it's time to discharge, and a client will say, yeah, I knew you didn't care. I knew you didn't care. And that right there, that sometimes is a phrase that would get me going, where I'm thinking, I've got to fix this. I can't leave it like that. The you don't care, or some variation of that, used to really get to me. Now I realize that's another way of pulling me into their story, making it so that I feel an urge to rescue, and it feels like it's my responsibility for them to change rather than it being their responsibility, which it is. I know we're gonna be talking about how we collaborate with our clients and work together. The next module, the next sessions are going to be touching on that, so we'll do a deeper dive on that later. So the urge to rescue is one response. Look, a lot of people who go into these type of helping professions, they're very caring people, very compassionate, and so we want to make their lives better. But sometimes that impulse actually makes people with personality disorder worse, not better. So we have to think about what's best for our client, not just what satiates our feelings of wanting to get rid of our anger or our fear or our sadness that come over us when we watch how they're living. And then the other typical response when we have this difficult clinical situation is we feel an urge to control or distance or even sometimes punish our clients. So what I mean by that is, if someone's making us feel afraid, we might feel like we need to control the outcome. We feel like, okay, you know, someone says in the middle of a session something like, okay, well, after we're done here, like you haven't been helping me at all, so I'm going to go self-harm. Then we feel like we've got to make them do a particular thing. Like, you have to call the crisis line. You must go to the emergency department and keep yourself safe. No, they don't. All of this is voluntary. It's all based on free will. They don't. We can recommend that. We can document that. We can consult with our peers and leadership about that. But actually, it's their free choice to live their life how they want. And that's got nothing to do with us. When it comes to wanting to distance, what I mean by that is, let's say you're working with someone and they've been giving you email after email. I've done many consultations for many clinicians who are saying, oh man, I've got so many voicemails, I've got so many emails. They come to my office, it's not even their appointment time. What do I do? And after a while, we can feel kind of burned out. We can feel like a lot of pressure, and then we can try to even create more distance. maybe we don't get back to them right away. We don't call. We leave them. If we've got a stack of calls or emails we got to create, we just put them at the bottom of the list. Why are we doing that? Because we're feeling helpless. We don't know where to turn, and we need to think about another way of working with them besides just distancing ourselves from them. In terms of punishing, this can be very subtle. It's not like we're actively harming them, but we might read them the riot act regarding expectations and rules. So let's say I've got a client who's coming into my office and they're late again and again and again. And that's part of their clinical presentation. That's part of the challenges of what they're working with. And believe me, if they're treating us like that, that means they're treating other people like that. And sometimes their unconscious is trying to communicate something to us. So if I've got a client, let's say, who's 15 minutes late for a session every time. Now, I could take the position of I'm going to punish them. I'm going to get really strict about you showing up at 10 o'clock. Like we had an agreement. Like I can entrench in my position, or I could say, wait a minute. I could take a step back and go, well, they keep showing up 15 minutes late. Maybe an hour session's too long. Maybe that's their way. They have trouble with communicating in the first place, but maybe that 15-minute delay is they want a 45-minute session, but they don't know how to express that. They think it's supposed to be an hour and they're supposed to be doing an hour, and that's their way of dealing with it. It could be lots of different things, but the idea there of getting really strict about it, saying, look, if you don't show up on time, that's it. We're not going to work together, or you're not taking this seriously, or these types of things. They're doing the best they can, honestly. So we have to get creative, and we have to communicate even better in order to help them figure out what's going on inside and use words rather than behaviors to try to show us where they're struggling. So those urges to control or distance yourself or punish them, we can feel them. It's totally fine to feel them. It can be very frustrating to work with someone who has personality disorder. I would be shocked if you don't have strong negative reactions. The reality is you're allowed to feel them, just don't act on them. So we've got to think about, when we have these strong feelings inside, what do? All right, so some ideas around what is good care when someone has personality disorder. What can we do that's constructive, helpful, useful? Well, one of the things I'm going to emphasize is structured, consistent care. Often when people have a personality disorder, they come from a chaotic background. It's very clear not everyone has suffered trauma when they've had personality disorder or have a personality disorder, but many do. And what happened to them when they were younger is either they were abused or neglected. And what they need in order to increase that trust is they need you to be consistent, to provide structure. If a session starts at 10 o'clock, it starts at 10. And if it ends at 11, it ends at 11. Don't go to 11:15, 11:20, 11:30 when 5 minutes beforehand they say, oh, by the way, 5 minutes to 11, they say, oh, by the way, the police were at my house last night. There was a domestic violence incident. I guess our time's up though, so I guess we really can't get into that. They pull the pin and talk about that 5 minutes beforehand. Why? They want to see if you're going to care about them. Are you going to give them extra? Are you going to give them more? I'm not saying to do that all the time like that. Sometimes people honestly think of it towards the end, but that is something I found as a common pattern. They'll mention something just before they have to go. I have found it increases my anxiety or my frustration. Like, why would you mention it 5 minutes beforehand? But there's a reason why. And we're going to get into that in other modules. But for this case, what I'm saying to you is they'll trust you if you're consistent. If your appointment is on Thursday at 2 and you're there from 2 to 3, and if they show up 15 minutes late or a half hour late and it's from 2 to 3, you're going to see they're going to start to trust you because your words and your actions match. That's really, really important. It's a very strong indicator you're someone that can be trusted. That's why on another video, I'm hoping to get into what I call the therapeutic framework. There's some amazing dynamics that we can create as clinicians, as workers in our organization using policy effectively in order to help people who have trouble and suffer from a personality disorder. So structured, consistent care is one. The other is that we want to definitely have compassion. We want to provide support for our clients and help them in a constructive way. And the other thing is that we have to set limits, and we've got to challenge their behavior sometimes. That's going to be in a future module. So these three things around structured, consistent care, providing compassionate support, and setting limits, those three skills together form a plan that can be very, very helpful for someone with personality disorder. I do consults on this all the time, and those are three keys that I point out, whether I'm consulting in forensics, if I'm consulting in seniors mental health, if I'm consulting in phys med or rehab, or with mood disorder. Those three things are pillars to work with in terms of how to provide good quality care for someone with a personality disorder. Next is we want a supportive, collaborative relationship. We don't always dictate terms, and they don't always dictate terms. We have to find a way to work together, find a way to hear what they want, and then we know from the research and from what we're doing what is useful and beneficial to them. And then finding that over time, creating that therapeutic alliance, so important, where they feel like they can trust us and tell us what's really going on, and we feel like we can be honest and open with them and tell them what's going on that we think could be of benefit to help them move forward. One of the things I really admire about Marsha Linehan is she assumes that clients are competent and responsible. You know, I found this in Greenson, I think, in 1967, and he was saying that if you treat a client like a child, don't expect them to act like an adult. What an amazing idea, because when people have, in particular, borderline personality disorder, it feels like they need your help. You need to wrap services around them in order to keep them going. Whereas Marsha Linehan says, assume they're competent and responsible, and that they'll learn the skills over time. It's just going to take practice. They might have to take a group more than once. They might need to work with you for an extended period of time. Research, on average, I'd say the research shows that a year, even 2 years of working with someone with personality disorder, and then they start to see benefits and long-term gains where it lasts longer than the treatment that you're offering. And then lastly, the idea that you need to talk to the other people on your team, you need to talk to leadership, and you need to talk to other community partners. How many times have I been involved in a consultation or a life care plan where people are saying, look, this other organization doesn't understand what I'm doing. They don't understand our treatment plan, or the treatment plan here works fine for our agency, but this agency is saying they need this because of their mandates and their policies. So it's really, really important, especially if a client's been going from doctor to doctor or a different psychologist, or they're going into the emergency room, that there's good communication with all the community partners that are trying to help. And when they're on your team, when you're working with your team, whether that's working with the people in crisis or on intake, or you want to explain with leadership why you're taking the position you're taking, you have to have really good communication, good documentation. It has to be that the position you're taking is defensible, it's actually sustainable, you can keep doing it over a long period of time, you're engaging in your self-care, and that you're communicating effectively with people around you, so it takes the pressure off of you. It's so clear from having many years of experience working with people with personality disorder, is that you'll feel a pressure inside, like it's up to you. You've got to do something. You've got to go the distance to try to help them. And we've got to strike a balance between what we're offering, what our team is offering, what our organization is offering, and then providing realistic and helpful services in order to help them. I think that if we talk about team dynamics and our communication, it's when someone is in a almost a pre-verbal state at times, when they're regressing or they're just acting out, or they may not be able to tell you they're angry at you, but the next session they've self-harmed, and maybe that's their way of expressing, hey, I'm really upset with you. Some clients act in instead of acting out. Our communication has to be really, really rich and clear with the people that are trying to support them, so that we're providing a consistent message, we're not getting in each other's way, and we're actually looking at the client as a whole and then we're able to help them if this is a good time to help them, that we can help them make some new choices, some better choices, something that's going to help them with their with whatever they're struggling with, whatever they're presenting, whatever they're saying they want to change, that we can then do something about it. So in order to do that, we need to keep three things in mind, right? This comes now down to the limit setting. We've got to have empathic and reflective listening rather than just responding to every demand. If you get into responding to every crisis they have, it can start putting you in a state of crisis. Got to step back, got to slow it down. We've got to listen and hear what's underneath all that strain and distress. Okay, so one part of really being effective and helpful is listening and letting it come in and feeling what's going on inside of us, because often our feelings are a clue for what's going on inside of them. We've got to be really clear about our bottom lines. Can't emphasize that enough. Are you going to be able to say if a client is physically or verbally aggressive, that's enough, that you can set a limit there? Because I've worked with some people who can't, and knowing what your bottom line is, it's important to have a conversation with leadership. It's important to know what your policies and the rules are of your organization. You've got to know what the limits are and what you're willing to tolerate. Easy example, I was working with a physician on a life care plan at the emergency department at a hospital, and he was saying that there was a client coming in who had a personality disorder. She was repeatedly coming to the emergency department and then spitting at staff, right? Yeah, that's not okay. We have to know for ourselves, what are we willing to tolerate in the workplace? Is it actually helping the client? If we don't do something about that, if we don't put in some type of implementation, same with physical safety. Do another consultation where the client had a knife to their throat in the room while the clinician was trying to work with them. So, our limits around what we're willing to do, it's very, very important that we figure that out. Got to think it through once, be smart about it, and then we can move forward. And so the clarity about bottom lines is really, really important here. And then the other thing, and the last point I want to make, is that if we're too flexible with our clients and they already have an unstable, uncertain sense of self, if it's already chaotic inside, and I'm talking about those elevators moving around and different thoughts spinning in their mind, us being flexible and accommodating what we think is supporting doesn't always work for them. In fact, it can make it worse. If we say we're willing to meet at different times, or we're gonna reply to texts at 10:30 at night or on the weekends, and that client starts to consume our life or consume our caseload, and we're trying to be there and be there and be there. Why are we trying to be there? It's often because we're afraid something bad's going to happen to them. But here's the reality. The reality is that if they hurt themselves, 10% of people complete suicide when they have borderline personality disorder. Okay, it's just part of the risk of the work that we do. And even if we were there and we lived in their house, we couldn't stop them, because they might go to sleep and we go to sleep and then they can hurt themselves. We have to accept there's limits to what we can control, what we can do, what services we can provide. If we try to be acrobatic and super accommodating and we're trying to respond to all their competing demands, we can make it worse for them. Because what if we stop? What if we give mixed messaging? What if sometimes we do something and other times we don't do something? That if it's already chaotic inside, the thing they need most from you is structured, consistent care. I'm not talking about being very strict with rules, rather that we just know what they are, we're expressing them very clearly, and then we're helping them work with us so they know what the expectations are, they know what the rules are, they have a sense of role clarity. Here's what I can help you with. That I can't, I'm going to have to refer you somewhere else. Trying to do all things for people, it just doesn't work in the long term. Why? It's not sustainable, and in the research it shows it's not actually helpful. So thinking about how much flexibility or how much support you're going to offer versus how much challenge, I'm going to talk about that dynamic in the next module when we get into the DBT, Dialectical Principles for Effective Therapy. Hey, I hope you've enjoyed watching this. If it's the first time you're meeting me, I suggest you consider hitting the subscribe button. I've really enjoyed making this for you. I hope it helps you with your practice, and you can reach out to me at michaelbruinix@gmail.com. That's MICHAELBRUINIX @gmail.com. And if you have any questions or concerns,